Actually, to be honest.
To be honest.
To be honest.
To be honest.
Actually, to be honest.
To be honest.
TBH.
TBH.
To be honest. Actually, to be honest. Hi guys, welcome back to our third episode, week 3 of To Be Honest, the podcast. If you're new here, my name is Annabelle, and To Be Honest, the podcast is a health and wellness education platform. And pretty much our goal is to provide free and accessible resources to teach you guys about your anatomy and medical terms and medical diagnoses so that you guys don't have to binge watch 12 seasons of Grey's Anatomy or get a crazy HECS debt. So that's our plan. And if you have been following along and listening to all of our episodes, then thank you. And also make sure to follow on whatever platform that you listen to our episodes on so that we can continue to grow and keep providing you guys with health education. So today's episode is called a mini medical. There will be multiple mini medicals in each season of To Be Honest, the podcast. And essentially their purpose is to provide you guys with a couple of different medical diagnoses that we will cover in the one episode. And there will be more common things that you would hear in everyday conversation or if you went to a GP. So we will teach you guys what they are, what are the causes, what are the symptoms and what do they look like, and also how do we treat it. So we'll cover usually 2 or 3 in each of the mini medicals. And in today's episode, we are going to cover UTIs, sleep apnea, and POTS, which stands for postural orthostatic tachycardia and hypertension. And if that sounded like a whole bunch of word vomit, then that's fair enough. But you will, by the end of this episode, have a good understanding of all 3 of those diagnoses. I hope everyone has had a beautiful week. I've had a pretty busy week. I've been on night shift this week and I'm also training for the City to Surf. So, wow, I got through 2 whole episodes without mentioning running. But if you didn't already know, I am in a cult and I joined August of 2023 and that cult is running and it's out of hand. I have run 2 half marathons this year and I'm about to do the City to Surf in Sydney in like less than 3 weeks. It's crept up on me so quickly and I think I was massively overconfident with this one. Normally with the half marathons, I had training programs and I was like super pumped and motivated, but I've been so busy lately that I've sort of let this one get away on me. It's a 14K run. But apparently, I've never done it before, but apparently it is going to be a killer. It's all uphill, whereas where I run here in Brizzy, it's all flat. So that's a bit of a problem and that's probably going to come bite me in the butt. So we'll see how we go. But yeah, that's kept me really busy this week. My training for it looks like I'm doing 2 5Ks, a 10K and a 15K this week in training. So yeah. That's where we're at with that, but it's kept me nice and busy. So that takes us nicely into the baby pod of this week. Again, my obsession for naming everything. If you are new here, baby pods are essentially like a little kind of health tip or advice or mini education on a topic that we do at the start of every episode, regardless of the sort of topic of the episode. So this week we are going to have a chat about using gels when we're running or doing long distance exercise or long duration exercises. So yeah, we're going to get into gels. I will be speaking from personal experience and like basic general understanding. There will be an episode later in the season on the science of running, and that in that episode we will have more experienced people discussing it. But yeah, I can give you guys a little understanding of it and also share my experience with running gels. So if you haven't heard of running gels, they are the little packets of like this gelatin type gross type of texture that you take with you when you're doing a long distance run. And when I say a long distance run, honestly, I'm more referring to time over distance. If you are running for 60 minutes or more, then I would recommend using a gel. I wouldn't probably use it for under an hour just because it's not necessarily required. But again, it also has a lot to do with your diet during the day. So if you are someone who is running at the start of the day and you haven't had anything to eat, then you might take a gel for a shorter run or a shorter duration of time. But if you are sort of running midday or later in the afternoon when you have eaten one or more meals and you've eaten some carbohydrates throughout the day, then I probably wouldn't recommend using it for under 60 minutes. Like using a gel if you're going to be running under 60 minutes. Essentially, when you are doing a long duration run, then we are going to need fuel. And that fuel is known as glycogen, which we store in our muscles. And the purpose of running gels is to replenish those carbohydrates and keep our fuel up so that you can achieve whatever running goal that you've set out. Generally speaking, we have 350 grams of carbohydrates stored in our muscles and roughly 80 grams in your liver and bloodstream as well. So in a 60-minute run, like I said, on average, generally speaking, you can burn up to 160 grams of carbohydrates. So if you have 350 grams stored and you're going to burn 160 in an hour, then you're almost using half your carbohydrates fuel. So you're going to fatigue really quickly after you hit that sort of 60-minute peak. So to give you a understanding of what a gel is, essentially it's made up of carbohydrates. Some of them have glucose and also caffeine in them. So it's really important that if you're going to start using gels for distance running, that you have a little read of the contents inside the packet, because I can't use the caffeine running gels. I use the carbohydrate-based ones with a small amount of glucose. Make sure that you are testing these gels before you go for a run. Everyone who has used caffeine gels has a horror story. So make sure that you are not waiting until the race or like a goal to use the gel, because you never know what's going to happen. You may need to run yourself to a public bathroom if you haven't used them before. So check that contents list. Like I said, I prefer to use the carbohydrate gels with a little bit of glucose, but the glucose in it is only going to give me that quick hit, that fast acting energy release, whereas the carbohydrates in the gel is going to be a slower acting, slower releasing energy and fuel burning. So if I'm having a really bad crash and I'm trying to hit a time or achieve a new goal with my splits, then I'm going to take that glucose and carbohydrate gel. It's going to give me that little shot of confidence and also that slow acting carbs to keep me going through for however much further I have to run. And I cannot use the caffeine ones purely because when I'm running, my heart rate is really high. It doesn't matter how fit I think I'm getting or how easier distance might become for me. My heart rate sits really high when I'm running. So if I'm sitting at 165 beats per minute for my heart on a distance run, then I don't need any caffeine to send that flying, because I end up with heart palpitations and headaches and all of these awful feelings. I get really tight in the chest and it's just all downhill from there. So that's why I stay away from the caffeine ones. Whereas some people they love the caffeine ones and that helps give them all the energy for their run. So definitely try them out before you commit before a race. And that's my little tips and advice. Like I said, we are going to have a Science of Running episode later in the season. But for today, let's get into the episode. So first up on our mini medical is a UTI, which stands for a urinary tract infection. And if you have listened to the episode last week, then you'll be a step ahead of the rest because we talk about the renal system. So to give us a little rundown on the anatomy again, we have the renal artery, the kidneys, the ureter, the bladder, and the urethra. So that makes up our renal system, and the bladder and urethra there refer to our urinary tract. So that the term itself, urinary tract infection, sort of gives us an understanding of what we're talking about. I would say that they are quite common. Most people, especially women, have experienced a urinary tract infection and they're pretty awful. So what causes it? It can be caused a few different ways. You can either get a pre-existing bacterial infection in your blood that makes its way down into the renal artery and sort of gets filtered through the kidneys and down into the bladder. Or more commonly, you receive the infection via the exit of the urethra and that sort of exposure to bacteria, which makes its way back up the urethra and into the bladder. And the other one, which is very common in teachers and nurses, the longer you hold your wee, the longer that bacteria that your kidneys are filtering will sit inside your bladder and sort of brew a cheeky little infection. So that's why when we talked about it in the last episode, drinking water and staying hydrated is so important, because it's going to flush out our bladder and stop us from getting UTIs. So the causes, I would say the big ones are that sort of retention, holding that wee inside your bladder for too long and not letting that bacteria flush through. And also then at the exit portal of the urethra, making sure that it's kept clean. So for both men and women, making sure that you are having good hygiene, changing your underwear, showering every single day, and also trying to clean yourself as much as possible after sex, and definitely weeing after having sex, because there's going to be a whole bunch of bacteria and little germies involved in all of it. And if you don't wee after sex, then that is going to sort of sit around the urethra there and sort of brew a cheeky little infection. So if you do wee, then that sort of acidic urine is going to sort of pass through, get it all out, and then obviously you'll wipe and clean yourself as well. So you are significantly reducing the risk, as opposed to just sort of chucking your knickers back on and going about your day and sort of letting it brew there. So sorry for that image, but that is essentially the reality of it. So if no one has ever told you this before, pee after sex. Absolutely. Guys and girls, everyone should just pee after sex. It will significantly help, okay? And it's just, you don't want to get a UTI, because when we talk about the symptoms of it, burning, feeling sensations, you can become really unwell. You can sort of get this pain and ache in your abdomen as well, where that infection is brewing inside your bladder. You can then have episodes of having to wee all the time, or feeling like you have to wee all the time, and then going to the toilet and not being able to wee. So there's lots of problems that come with that and with an infection, and those symptoms can be pretty awful as well, especially the burning feeling. It's so bad. It feels like fire. It feels like fire ants every time you try to do a wee. So yeah, just fix that problem quickly so that you don't develop a UTI and end up with these symptoms. The other sort of concern as well with a UTI is urosepsis, which is when that infection goes sort of dismissed for a long amount of time. So you might think you have a burning sensation when you wee and all of that, and you're like, oh, I think I have a UTI. You don't really treat it. It progressively gets worse, especially in older people as well, in the elderly. So in your grandparents as well, make sure that you're looking after them and checking in with them, because if they are experiencing that, or you are experiencing that, and it goes dismissed for too long, then that infection will just continue to brew. And if your body isn't able to fight it off, then it will continue to grow and sort of end up in your bloodstream, and you will end up septic, where that infection is winning, essentially. It's winning the battle, and your body's not able to fight it, so it's starting to take over, and then you end up becoming very, very unwell. And urosepsis is definitely a cause of death that is seen too often, and it's very sad. And UTIs are a very common presentation to emergency. So how do we treat it? Like I said, if you have been experiencing any of those symptoms that we talked about, or you've noticing that you are starting to have a burning sensation when you wee, or this sort of change in frequency of weeing, or you can't wee, or there's pain or headaches, starting to get a fever or unwell, and you're like, this sounds like a UTI, then I would recommend going to see the GP. First and foremost though, drink 2 liters of water. Flush your system. That's a really quick fix. I've definitely treated a UTI before just by drinking water for the rest of the day and getting that flushed until it burns for the first few wees, because obviously you got to keep weeing because you're drinking a lot more water, and it really it burns for a while. Having warm showers, drinking lots of water, and then eventually that burning sensation starts to go away, and your urine is nice and clear again, and you're like, okay, we've flushed it, we've passed it, and you just keep that hydration up for the next couple of days, keep flushing it out. And I've resolved UTIs in the past by doing that. But if it's not going away, and when I say going away, I'm saying 2 or 3 days of burning every time you go to do a wee and it's getting worse, go to the GP and they're going to prescribe you with some antibiotics. And you can take usually 3 days of it, or 3 doses of it, and it sort of hits it on the head. But first and foremost, try the non-antibiotic methods first. Don't just jump straight into antibiotics. Try and treat it with some water as well. And then if it's getting worse, absolutely see a GP and get into some antibiotics for that one. So that's UTIs. And the next one up on the list is sleep apnea. Okay, so sleep apnea is becoming a big thing. And it's not something that is new. We've definitely had sleep apnea forever. We're just finally looking at it and being like, this is so not normal. And this is actually a really bad thing. And the CPAP machines, like CPAP, CPAP machines are a great resolution to fixing the sleep apnea problem. So firstly, what is it? Because it's likely that your dad has a CPAP machine at home, or if you're a nurse, then a lot of your patients may end up coming into a hospital, especially your post-op patients, and they're going to have that CPAP machine on. Essentially, sleep apnea is referring to the occlusion of that soft palate that sits where your tongue is. So where the tongue, sort of that gap between the tongue and the back of the throat, that's your soft palate area. We have a hard palate, which is sort of further into the mouth, and the soft palate is further back near the back of the throat. And that sort of area, when you're lying down, especially on your back, is like the tongue sort of tends to drop back a little bit as you're resting, especially when you're asleep, because essentially the tongue is a giant muscle. So what starts to happen is that airway starts to become occluded and you end up with that awful snoring sound. But the worst problem is that you're getting less air in during the night, and there are different stages of sleep apnea, but you can have a smaller stage where you're having just a couple of episodes every night where you're getting reduced airflow. But in more extreme cases, you are actually having episodes during the night where you have full occlusions and you're not taking a breath. And that is when your sympathetic nervous system kicks in and you are going to sort of wake up to a startle. Most often than not, you don't even realize you wake up, but your body sort of wakes you up. You might take a cough. You might have a big deep breath and go back to sleep. But that's happening multiple times during the night where you're having an episode of reduced oxygen to the brain. So we need 95% or more oxygen to maintain healthy brain function and organ function. So if you've got 95% or more, we're happy. If you tend to sit at that 94, 93, we're like, ooh, let's get on to some sort of breathing exercises so that we can improve our ability to consume oxygen and take deeper breaths during the day. Breathing is something that we do subconsciously. So when we're asleep, not only is it subconscious, but you end up having these episodes during the night where your oxygen can drop to below 90 and you're having quite significantly reduced oxygen to the brain. And then you wake up the next morning with these symptoms like headaches, fatigue, fuzzy brain, and then you can end up having high blood pressure, a dry mouth, really bad snoring throughout the night. These are all symptoms of that sleep apnea, and you feel awful during the day. What causes it? Like I said, it's that strength of the tongue and the soft palate, and that can be weakened by age, by weight, and essentially some people are just born with stronger or weaker soft palate muscles. So you can end up with 15, 16-year-olds who have sleep apnea as well, but it's more common in men around the age of 50 to start to require a sleep apnea machine overnight. And yeah, it's how we are going to diagnose a sleep apnea sort of case by having a sleep study where they send you home with it. You can sleep with it overnight, and it analyzes your sleep patterns and how many episodes of sleep apnea that you have per night. And some people can have 100 episodes over the night of that occlusion and not getting oxygen to the brain, and that oh my gosh, deep breath, I haven't had a breath. That people have it that bad, and it's really, really bad, and we have to get on it and we have to treat it correctly and be very compliant with the CPAP machines. So let's say we understand what it is. It's that occlusion of the soft palate and the tongue muscle where we're actually having an occlusion during the night. You're reducing the oxygen flow to the brain as well. We know that our age, our weight, and our strength of the soft palate and tongue muscle can cause it. The symptoms look like headaches, fuzzy, fatigue feeling, generally unwell, also loss of patience, high blood pressure as well. And of course, you're going to end up with snoring and a very dry mouth as well. How do we treat it? Once you've had that sleep study done, then you are going to use a CPAP machine. So that is a continual oxygen delivery system that is used either via like a Hudson mask or a sleep mask, which is kind of like covers your nose and your mouth. But some people only require the nasal prongs, which is just like this little like bands and sort of a nose piece, then is attached to a tube. So it's not the most attractive machine. But you do then plug that into the machine, which has a little screen on it, a little dial, and a little tank, because that tank is going to be filled with water all the way up to the line that you'll have to redo every night before you go to sleep. You fill that water up to the line, plug it back in, and that's going to humidify the air and delivery provided to you overnight. So the point of it is that when you are having these episodes of that occlusion or that partial occlusion, you're still getting saturated oxygen into your body, so you're not having that loss of oxygen flow to the brain during these episodes throughout the night. And it also does an analysis as well, so every night you'll be able to see how much oxygen delivery you received and how many episodes you have, and it can be a little bit competitive. You sort of got to get better at it every night and make sure that you're wearing it, because that's the other thing. The CPAP machines will tell you if you've taken it off during the night. So that's sleep apnea. And finally, we are going to be covering POTS. So POTS is an abbreviation for the medical term postural orthostatic tachycardia and hypertension. Let's just break those words up quickly. So the first two words are postural orthostatic. So postural is just referring to our posture, the way that the position that the body is in. And orthostatic is referring to that 90 degrees sitting position or standing up. So those two sort of up vertical position. So a postural orthostatic position is the body sitting up 90 degrees or standing. So that's literally just referring to what our body is looking like for this diagnosis. So postural orthostatic, sitting upright or standing. And then the next word is tachycardia. So we've got P-O-T. T is for tachycardia, which is a rapid increase of the heart rate. So our heart normally sits where like sort of 60 to 100, 100 being like more drastic. And usually if your resting heart rate's 100, that's going to be further investigated. But if you're going to be sitting in a position or lying down, then it can sit in that 50 to 60 even. So when we have tachycardia, we are referring to that rapid increase of the heart rate. So if you're going to go from, say, 60 beats per minute, then all of a sudden we have a jump of 40 beats per minute up to 100, then we're experiencing tachycardia because we've had this rapid increase in heart rate and our heart is now sitting at an abnormal rate for the situation that you're in. So you could have a really high heart rate watching the Annabelle horror movies, but that doesn't necessarily mean you have a diagnosis of tachycardia because it's situational. So when you are just lying down in a normal position and then you sit to a postural orthostatic position and you have tachycardia, then we are diagnosing the fact that that simple movement in a controlled environment is causing a rapid increase in heart rate, and that is abnormal. So that's how we end up with that POT, POTS word, and that diagnosis of postural orthostatic tachycardia. So I also added on the end of that hypotension, which is hypotension, meaning low blood pressure. And there's sort of that second, like part B of this diagnosis, and that's postural hypotension, where when you sit up or stand up, not only is your heart rate increasing, but your blood pressure drops. So when you're lying down in bed, the sort of pressure and volume required to get the blood down to your feet and back up to your heart is pretty minimal because there's not a lot of effort required. You're not working against gravity. It's sort of pumping it around the body and you're lying nice and flat. All of a sudden, when you sit or you're standing up, your legs are below your heart rate and it now requires to go against gravity to back up to the heart. So you're going to have that increase in blood pressure. However, if you have hypotension, that means that your body isn't able to correctly regulate and understand that, oh, we have to just a little bit increase our blood pressure to get that blood back from our feet up to our heart. And it just drops quite dramatically and quickly, and the blood runs down to our feet and it doesn't come back to our heart quickly for that return of blood volume. And that's got multiple complications. So if you're experiencing lightheadedness or dizziness every time that you're sitting up, then you would need to go down the path of investigating for POTS and postural hypertension. So one more time to go over those words so that they make so much sense. The POTS hypertension word stands for P, postural, O is orthostatic, so postural orthostatic, T stands for tachycardia, and hypotension. So essentially we have when our body is sitting in an upright or standing position, we have a rapid increase in heart rate and potentially a drop in blood pressure. That's all that acronym is telling us, just in lots of different terms. What causes it? Essentially, like I said, that literally the change in position has caused that sort of failure to regulate that blood flow, and when you sat up quickly, the heart is sort of freaking out. It doesn't know what's going on. There's that blood pressure change and it's unable to sort of understand and comprehend the situation, so your heart rate jumps quite rapidly and quickly. So the symptoms, like I said briefly, that lightheaded, dizzy, and more often than not a fainting episode when quickly going from that sitting to standing, or that lying sitting to standing change in body posture. The other symptoms that you can experience with POTS is also panic attacks and chest pain, and that is triggered by that tachycardia, by that rapid increase in heart rate. And all of a sudden you can experience that sort of difficult to take a deep breath, that freaking out, and all of that is just triggered because your heart rate's now going so much faster than it was 0.5 of a second ago when you just sat up. So how do we treat it? Unfortunately, there isn't a black and white answer for the treatment for POTS. There are a lot of management advice and plans to sort of manage the symptoms, but there isn't a quick fix treatment for POTS. Some people, depending on the severity of their POTS diagnosis, might go on some regulating medications, cardiac medications. You would see a specialist cardiologist for that kind of investigation and that prescription, but a general diagnosis would be managed by that regulation from lying to sitting to standing, and not having a quick momentum change in that position. So if you're lying in bed, so say you've been diagnosed with POTS and you're lying in bed in the morning, just making sure that you are taking your time, taking some deep breaths as you sit up into a sitting position, and then sitting on the edge of the bed for upwards of a couple minutes even. And then when you're feeling confident, potentially even have some water sitting beside your bed, drink a little bit of water, and then slowly start to get to a standing position. That becomes tricky if you have to get up to pee in the night, because you're a little bit groggy in the head, so you're not paying total attention, and it's awful. I shouldn't be laughing at it, but it's just an awful situation when you sit up on the edge of the bed. You're like, you wake up in the night, you have to pee, so you sort of get up, it's dark, you can't see around the room, and all of a sudden you conk out because that POTS has just been triggered, your blood pressure has dropped, you've got that rapid increase in heart rate, and you fainted on the bedroom floor, and you can't even see what's around you because of everything that's happened. So that's probably a really big risk factor to keep an eye out for. So yeah, monitoring how quickly you go from a lying to standing position. It's also important to note that POTS is more common in young women, especially around the age of menstruation, from ages 15 to 50. If you get any of those symptoms, make sure that you book in to see your GP. Okay guys, so that brings us to the end of the episode. We have covered 3 diagnoses in our mini medical today. We covered UTIs, sleep apnea, and POTS. So UTIs is a urinary tract infection, and sleep apnea refers to that occlusion of the soft palate and tongue during the night, reducing oxygen flow to the brain. And POTS stands for postural orthostatic tachycardia and potentially hypertension. which you now know what that refers to and what that means. So I hope this has been somewhat beneficial and given you a little bit more of an understanding if you've heard these terms before. And if you ever end up, needing to go see a GP for a UTI, you will actually have an understanding of what they're going to treat it and how they'll treat it. So yeah, you guys deserve to know about your anatomy and know about medical terms and diagnoses. And it's important to stay educated so that you can look after yourself the best way possible. But I hope everyone has a beautiful week and stay well. Also, stay well at this time of the year as well, because everyone is dropping like flies. Influenza is running havoc. Also, stomach flu and gastro is also running havoc. So keep an eye out, guys, and just stay well and look after yourselves.
Let's go.